Grüezi ragazzi, bienvenue, willkommen in one of our next live of our LinkedIn Live. Tuesday is now our weekly appointment. Usually we have different guests we've been showcasing so far in the past year, but we want to go back from where it all started. For the ones that have been following this channel for a while, you probably remember that very first LinkedIn Live we had was indeed a presentation, educational presentation from a very special guest, which is ourselves. And we are a science company, so we also have something that we can provide, and we want to continue on this educational trend. So for a few episodes now, we wanted to go back in actual training. And so for today with Fabio, we will be doing a little class on the pharmacology of one of our favorite compound, tetrahydrocannabinol, or famously known as THC. He will give you a presentation on slides, as you can see here. And if we'll have extra time, we'll do some readings as well from the book we just published, Principle of Clinical Cannabinology. Of course, as we've been talking about the use of this book a lot, obviously for all of its clinical sides, but don't forget that chapter 2 is actually all dedicated to the pharmacology of the compounds involved with cannabis and the health use in medicine. And of course, there is quite a lot dedicated to THC. So, for example, we delved into, of course, the pharmacokinetics. That is something that today in his presentation won't be touched. So in case we'll have some extra time, I'll also make sure to give you some excerpt from the pharmacokinetic of THC from this book, or otherwise, of course, you can always go on our website, cannabisciencia.com/handbook, and follow along with the handbook yourself. But now, without further ado, I would like to introduce you to our own very famous Dr. Fabio Turco, CSO of Cannabisciencia, that will give us a tour in the magical world of THC and its pharmacology. Thanks a lot.
Thank you, Viola. Hi to everyone, and welcome to this very brief lesson on the pharmacology of phytocannabinoids, in particular on THC. So let's start to talk about cannabinoids, that are a group of chemicals which bind to the endocannabinoid systems. Basically, we have three types of cannabinoids. We have endocannabinoids, that are naturally occurring compounds produced by our body that regulate various physiological processes such as pain sensation, appetite, and mood. They accept this effect by interacting with the components of the endocannabinoid system, which I like to remember, regulate homeostasis. That is the balance between all the organs, apparatus, and components of our body. Then we have phytocannabinoids. They are also naturally occurring compounds produced by the cannabis plant. They also have the ability to interact with the component of the endocannabinoid system and exert various effects on the body and the mind. Finally, we have synthetic cannabinoids, that are synthetic compounds designed to mimic the structure of natural cannabinoids. Synthetic cannabinoids was produced to be used for medical purposes, but they are not very much used for this reason, because they are associated with a wide range of side effects, including the induction of psychosis, cardiovascular problem, and so on. But they are very useful tool for research purposes, and they have also limited application for medical condition. Oh, sorry. So let's talk about phytocannabinoids. We have almost 150 phytocannabinoids that have been recognized so far in the cannabis plant. They are there are various cannabinoids, but the most famous one are surely the delta-9 tetrahydrocannabinol or THC and cannabidiol or CBD. The biosynthesis of phytocannabinoids in the cannabis plant is a complex process that involves many enzymes and chemical reaction. Briefly, it starts with the production of the geranyl pyrophosphate and olivetolic acid. Then these two compounds are bound together by the action of an enzyme called CBGA synthesis. This produces CBG acid or CBGI, that is the precursor of all the major phytocannabinoids. After this process, CBGA undergoes a series of chemical reactions to produce the other major phytocannabinoids. The specific enzymes and chemical reaction involved in this process vary depending on the phytocannabinoids being produced. This process is regulated by a complex network of genes and enzymes, and also environmental factors such as temperature and light can influence this process. In the cannabis plant, phytocannabinoids are produced in the acidic form. When we see the A at the end of the name of the compound, it means that it is in the acidic form. After being produced in this form, phytocannabinoids undergo a process called decarboxylation. That is the removal of a carboxyl group or a carbon dioxide molecule from the structure of the compound. This process can occur naturally, but it's very slow. It can be speeded up by the action of heat or by drying. Acidic phytocannabinoids have different properties compared to neutral cannabinoids. Indeed, acidic phytocannabinoid cannot pass when in our body cannot pass the blood-brain barrier. So the effect they exert are restricted to the periphery of our body. Indeed, the neutral phytocannabinoids that are more lipophilic can pass the blood-brain barrier, and so they can exert their effect also in the central nervous system. Phytocannabinoids exert their effect because they can interact with various targets on our body. In this slide, we can see some of the receptors that are activated by phytocannabinoid. And as you can see, both phyto and endocannabinoids can act on the same receptors. By acting on these receptors, phytocannabinoids are in part responsible for the action of the cannabis plant. They can exert a lot of physiological effect, and they can also exert various beneficial property in various pathological conditions. Now let's see what are the effects exerted specifically by the THC. THC is a partial agonist of the cannabinoid receptor CB1 and CB2. The action on the CB1 receptor that are localized mainly on the central nervous system is responsible for the psychoactive effects of THC, as they can help to modulate pain sensation, mood, appetite, and other function. THC can also bind to CB2 receptors that are localized mainly on immune cells and in the peripheric organs. And the action of THC on CB2 receptor is responsible mainly for the anti-inflammatory property of CBD. By acting on CB2 receptors, THC can also exert neuroprotective effects. Indeed, CB2 receptors in the central nervous system are localized mainly on astrocyte and microglial cells. By binding to these receptors, THC can induce a switch in the phenotype of this cell from an inflammatory phenotype to an anti-inflammatory phenotype, and this is why THC can exert neuroprotective function. Other than the classical cannabinoid receptor, THC can also activate other receptors. For example, it can bind to TRPV1 and 2 receptor that are ion channels that can responsible for the entrance of calcium in the cells. And in this way, they regulate, for example, pain sensation and inflammation. So the analgesic and anti-inflammatory properties of THC are due also to the action on this receptor. Apart of this receptor, THC can also interact with other receptors, for example, GPR55, GPR18, and other receptors. Sorry. By binding to this receptor that I've shown previously, THC exerts a wide range of pharmacological effects. Indeed, for example, THC is effective in treating chronic pain, particularly neurotopic pain, because THC can reduce the sensation of pain and also increase pain tolerance. Moreover, it's effective against nausea and vomiting, particularly those induced by cancer therapy or debilitating conditions such as AIDS. It is also useful for AIDS-induced anorexia because it's an appetite stimulant. It's useful against spasticity, such as that induced by multiple sclerosis, because CB1 receptors are localized in the center that regulates motor coordination, both in brain and in the spinal cord. It can be effective in treating Tourette syndrome. Indeed, THC can reduce tics and other symptoms of Tourette's syndrome by modulating dopamine release from the central nervous system. THC is effective in treating epilepsy. Indeed, it can reduce seizure because it reduces the neuronal excitability. It has been found, it is a recent finding, that it can be useful for brain injuries or stroke because it is able to reduce the area of stroke. We have seen that it can be useful in attention deficit disorder because it can improve the attention. Potentially, THC is useful in neurodegenerative diseases such as Alzheimer's, Parkinson, and other, because it is able also to reduce the inflammation and the oxidative stress in the central nervous system. It can be useful for anxiety or depressive symptoms, but here we must pay attention. Indeed, the THC can have both anxiolytic and anxiogenic effect, depending on the dose, the context, and also on individual characteristics. And also, THC can also have mood decreasing and mood activating effects, so it can be useful or not in case of depression. And lastly, we have seen that THC is useful in the withdrawal symptoms from substance abuse. Indeed, it can modulate the reward processes in our brain. But also here we must pay attention because prolonged or excessive use of THC can also lead to dependence and so also to withdrawal symptoms.
Fabio, I wanted to interject. Sorry if I interact and disturb you in your class. But I wanted to make this point really understood. Everything is really dose dependent. So if you are reading these things here, and rightly so, he's saying, some of these effects, like, watch out, because they're like incredibly dose dependent. But pretty much any of the effects that we're listing here are dose dependent, because let's not forget that cannabinoids are not going in pharmacology. We look at effects and doses, and if we have a linear line out of this, then you know that you increase the dose, you're going to increase the effect of that particular effect. But with cannabinoids, it's more like a bell, we call it bell shape. So there is a precise dosing that will give and provide that effect, but actually different doses will even give opposite results. And this is pretty much valid with most of these effects. Even think of nausea and vomiting, epilepsy, even attention deficit. So everything is very much dose dependent, and of course some of the most subjected to conversation and discussion, of course, is the use of THC, of course, for psychiatric or mental health disorders, where at certain doses it really can be really incredibly supportive, and at other actually can be detrimental. But can be extended for pretty much all of these areas. So just wanted to make sure that we are passing this concept through. But thank you. Sorry to interrupt.
No, thank you, Viola. This is a very important concept to outline. Indeed, when we talk about phytocannabinoids in general, we also see that they exert biphasic effects depending on the dose. Moreover, the same dose cannot exert the same effect in all the people, because also the personal characteristic of the person, that is how much the endocannabinoid system is, the component of the endocannabinoid systems are expressed or not, can influence the effect exerted by THC. And indeed, when we talk about THC or cannabis in general, we always talk about personalized medicine, because we have to make sure that that dosage, that compound, is tailored to that person that need to some help for some pathology. So this is a very important point. But apart of this, in this condition, THC have been proven to be effective in a lot of clinical study. So we have to find the right dosage, but we can be sure that we can find it, because it has been shown that it is effective. So these are the conditions that can be treated with the THC, but we cannot forget that also THC, like all the substances, can exert side effects. In this slide, there are the main side effects exerted by THC. We can see that it can induce memory impairment, increased heart rate, bloodshot eyes, dry mouth, reduced coordination, paranoid or anxious behavior, hallucination, dizziness. It can increase appetite. All of these can be side effects or medical effect, depending on the side we watch this. For example, for a person with problem of anorexia, the increase in appetite is not a side effect, but a pharmacological effect that we want to exert. Going on, you can
also for a person with PTSD, memory impairment is kind of good. So right, so it all really depends on how we're using it. But yes, sorry, I'm gonna be here like just
like
doing this.
this dialogue. Moreover, going on with this, we can say that most of these that are seen in medicine are side effects, are the effects that are used in the recreational use, that are the effect that people search for when they use cannabis for the recreative purposes. Going on, THC can lower the blood pressure, can slow the reaction time, can elevate the mood. It is sedative, so it can induce sleepiness. It can decrease concentration, can induce short-term memory loss, can impair the judgment, can render more difficult the problem solving, and can induce a distorted perception. Moreover, in some patients, in some people that have an history of psychosis in their family, or they are particular fragile individuals, THC can induce psychosis. We have to note that this side effect, as we were saying before, can vary in severity and may not occur in all individuals who use THC. Additionally, prolonged or high-dose use of THC might increase the risk of side effects, and this is also true for any substance that we go to analyze. This is my last slide, and I propose this slide because, as we can see, some of the effects exerted by THC are similar to those exerted by CBD, the other main compounds found in the cannabis plant. What is different in some cases is the potency of these effects, and this is because THC and CBD have a very similar structure, but we will talk about CBD in the next week. So, Viola, if you want to add something from our book, it will be really nice.
Thank you. Well, first of all, thank you very much for this short but very on-point presentation. We looked at receptors, we look at interaction of these receptors to some of the main effects. And at the end of the day, when we look at which area of localization, the receptors on which our molecules of observation is working in, then it's easier to understand effects, whether they're side effects or desired effects, because they're going to be coming from that area pretty much. But now, first of all, I wanted to open the floor as well. I see people mainly coming from out of Europe, so welcome, super welcome here. Canada, Argentina is super well represented. Hi, someone from Germany. But anyone welcome if you want to use this time to actually ask us any question. Otherwise, I'm very happy to continue with a little reading from, as I said, our second chapter of Principle of Clinical Cannabinology is entirely dedicated to the pharmacology of the compounds that really are used for medical purposes. And as you know, in the monograph that we use over here in Europe, which is the German monograph, there are only 2 compounds out of the myriads of molecules that have that are produced from this plant and that have in different stages of research that show their use, medical use, but only 2 of these molecules are recognized with the medical use, and those are the 2 molecules on which we are going to be focusing today, and next Tuesday we will be looking at CBD. So these are the only 2 molecules actually recognized for medical purposes. Hi, obviously there is someone from South Africa too. Okay, thank you for letting us know. If, as I see, there aren't direct questions, I'd like to jump into pharmacology of tetrahydrocannabinol. Something interesting that we wondered is, and I think is on point, is it possible to separate the side effects from the therapeutic ones? And this, of course, is an insight that I don't think I'm going to have the time to go through everything. But just to give you a broad idea of what we mean, as I see the word pharmacokinetic now filling up many conferences, but often I think there is still a misunderstanding of what it is. We studied ancient Greek, both of us in this life, so we can say with confidence that pharmacokinetics, nothing else is that it's 2 borrowed words from ancient Greek. Kinetics is like, think of cinema, okay? It's the same root of the word, and it's something that moves. So, and pharmacos is the drug, okay? So it's how does the study, that the type of studies that study how the drug moves into a body. And so obviously, depending on where we first intake or absorb this drug, it will change the route of the bioavailability, basically, of the drug. So we look at different absorption. As you know, we have different methods of administration of THC. Obviously, not all THC is inhaled. Actually, if I look at Italy, in the medical use, pretty much a majority at this point of prescription are done for a sublingual type of administration, meaning something that is entering the bloodstream in a kind of less direct way than an inhalation. But then we have other places from where it can be absorbed. And obviously, this will depend whether it will be a passage through the liver or not, on how much active principle will actually arrive on the target site that we want to act on. After the study of how the molecule and from where the molecule is absorbed, usually we look at the distribution rate. And every compound and every molecule has a different volume of distribution in the blood, basically. So we look at that for THC. Obviously, we look at this for the pharmacology of different compounds, but I'm just like giving you a sort of summary of what you can find, at least in this chapter for THC. We obviously looked at the metabolism and elimination, which are important aspects. Often, one of the most common questions you can get asked, if you know a little bit about an elimination of a drug from a body, is in how long after my last consumption of cannabis will I result positive in a test? And that obviously depends as well from the type of test, but not only, because the metabolism of these lipidic molecules, it's actually very, very interesting, and is not, again, a linear excretion, meaning that we actually retain in our body, in our fat storage, for quite some time. And so one of the factors that we need to factor in, it's whether it's a chronic use, or there is an history of like constant use, like, for example, through a prescription. Of course, there's going to be constant use because there is going to be at least 2 months of medication, 3 months of medication. So there is going to be some continuity over, instead, a naive use and just one-time use. It's going to be a different metabolism and an elimination. Also, it's kind of really interesting from a pharmacological point of view, looking at the metabolism, because we know that actually one of the metabolites of THC is truly the one that is even apparently more potent than THC itself, and is what is truly acting at the receptor. So the subtlety of the molecular receptor interaction actually should be evaluated further, especially considering pharmacokinetics. And so I believe that in tomorrow's research, and this maybe I open with a conversation with you, Fabio, since of course you're a scientist, but my thought and my idea on this regard is that tomorrow we will be able to study the pharmacodynamics, meaning the effects that the molecule managed to provide and to have in a body, in a biological body. Depending on what particular method of administration is carried out. I say it's easier, but I believe that we should look as well at the changes on pharmacodynamics, on the effects that we just listed, for example, now, whether that use is coming from a suppository versus an eye drop versus a topical versus an inhalation, because of course the logic is that of course the molecule doesn't change how it interacts with the receptor, but if it changes the let's say the ratio of that molecule, or the metabolism of that molecule.
Also the duration of effects.
Yeah. So
yeah, probably we will have more studies on this. I know that some studies have been done. For example, we know that there is a difference between inhaled cannabis or oral administration of cannabis, because the effects of inhaled cannabis are more powerful, but they have a less duration in time compared to, for example, oil drops or other oral administration methods. Maybe, Viola, we can answer to some questions that I've seen that our audience have done.
Sure.
For example, there is Carla that asks if we have any info on cannabinoids and hematocrit and hemoglobin levels. I can answer to this by saying that for sure THC and cannabis can modulate the hematocrit. Also in this case, the effects are vary on person to person. In general, I remember a study that had been done on hashish, and they have seen that it can reduce the levels of hemoglobin in young people. Moreover, it also influences other parameters, but now I don't remember specifically which parameters go up or down. There is also another question from Tim. He say it is very effective for ADHD. Can confirm this here many patients' voices describing a benefit also for autism. Well, yes, THC is also beneficial for autism. There have been a lot of studies that demonstrate this, but the problem with the THC is that autism always occurs in young people, children or teenagers. So even if it is effective, the side effect cannot be always tolerated by this population. So the compound that it's gained more attention because of autism is CBD, as we see in the next lesson, because it exerts also neuroprotective and antioxidant effects in people with autism, and this is very useful, for example, to lower the aggressive behaviors, and moreover, it does not induce the side effect typical of THC. But as I said, we will see this in the next lesson. Now I think it's time.
Absolutely, we can close it also reminding that, of course, we don't really believe in isolating one compound from the other. So I think what you're saying is usually what the major confidence also from coming from science and coming from the experience of clinicians, both for autism, but I would say also for refractory epilepsy. We've seen that only CBD in some instances is not effective, but when you have even really, really low percentages of THC that are not, in many cases, not even felt as a narcotic, because anyway the ratio with CBD it's really large. It seems to completely change the effect on the patient. So often it's a matter of at least intaking this knowledge and then balancing it out with all the knowledge from the other compounds and start to really think what can be of most support for patients. And yes, we managed to shut out a little few minutes over our half an hour scheduled, but we're very happy and look forward to invite you all for next week, same time, same people, but different compound. And we'll look at CBD and its pharmacology, and we'll also have time for a few questions on this. Thank you so much, and looking forward to that.
Thank you, everybody. See you next week.